tamin'ny voalohany nanaovana fampianarana anazy zany a da nosarosarotra avao. Kanefa niezaka zareo na mpianatry da ohatrany nalalaka be amizay, mora be amizay zany fampiasana anazy. Ka hatramizao zany komikera de efa hainay ampiasaina tsara.
Speaking on behalf of Damagi, our company is committed to improving the lives of millions and billions of people all across the world through frontline worker programs. We are most well known for our platform ComCare, which is one of the biggest and most widely used platforms for supporting frontline workers all across the world. ComCare has enabled workers like the one you just saw in Madagascar to support her community, deliver life-saving essential services, register pregnant women, and refer those women to clinics as needed. We're extremely excited by the work that we've done to date, supporting hundreds of thousands of frontline workers all across the world. But the work that we've done at Damagi and the work that our industry has done is simply not enough. These jobs are getting more difficult. COVID-19 has decimated our public health workforce, made these jobs harder, more time, more investment, with little to no pay improvement across the industry. What we want to do over the next 5 years is make sure we make a transformational commitment to support these frontline workers so that they can deliver better outcomes for their communities. And we think that primarily starts with better jobs. These frontline workers are doing critical, essential services in hard-to-reach areas. They're often the only point of contact communities, families, or providers may have to the healthcare system. Hospital may be 100 miles away for some of these communities. These frontline workers need amazing, empowering tools because they're doing a job that is extremely difficult and very critical for their communities. And as we saw through COVID, if we're not safe everywhere, we're not safe anywhere. These frontline workers also act as frontline responders for pandemics, whether those are localized pandemics or global pandemics like we just had with COVID-19. And these pandemics are popping up again and are going to continue to pop up, as we saw or are seeing with Uganda and the latest Ebola outbreak. Frontline workers like this can be responding quickly and adaptively, but they need strong support from the healthcare system in order to do so. We are just starting our journey on improving ComCare to add 4 key capabilities that are going to support these frontline workforces. We call these learn, deliver, verify, and pay. We think by improving these capabilities, frontline workers all across the world will be able to do additional work for additional pay, improving their jobs to improve outcomes. Our canonical example is early childhood development. This is a service every new parent needs to learn how to better take care of their children, to support growth, nutrition, and education. And learning these skills, whether you're in a high-income or low-income setting, is critical and difficult. Becoming a new parent is stressful. Having support from your community is critical. As we say, it takes a community to raise a child. And with additional skills, learning how to do early childhood development can be done by non-specialized providers who support communities and households, delivering these essential skills. They deliver these skills after learning and getting certified, and we can verify that these skills were delivered through GPS real-time data collection that governments, partners, and nonprofits alike can support with these communities. And finally, they can be paid in real time for these additional services that they're providing. If we can bring together learn, deliver, verify, and pay for things like early childhood development, vitamin A distribution, mental health, and other areas, we can further build on the critical infrastructure that community healthcare workers and frontline providers have already created. The investment in this workforce is already in excess of $1 billion a year. It's estimated that there's a 10-to-1 ROI on the money spent in these frontline programs, and yet 86% of this workforce is not full-time employed. Many are volunteer and not paid at all, or many are poorly paid. And there's somewhere between 7 and 15 million frontline workers in Africa and Asia alone. This workforce is one of the best healthcare investments we can make. And we are really excited to bring technology to empower this workforce, not just for what they're doing today, but for what they need to be doing tomorrow to be a responsive and resilient healthcare system to support their individuals, families, and communities. I'm really excited to hand it over to Dr. Tanya Elliott, who will speak additionally about her work in virtual care.
Thanks so much. And what important work you all are doing. So I'm Dr. Tanya Elliott. I'm an internal medicine physician and an allergist by training. And I've been in the telehealth space for the last 10 or so years, had multiple experiences across startup, payer, and most recently provider. And one of the things I'm most passionate about is assuring that clinicians and care teams have access to technology to enable and improve care for their patients. But not just that, but they understand how to interact with and how to use the technology. So that's everything from embedding telehealth training and education into medical school curricula and residency curriculum, as well as training around asynchronous or near real-time data collection through things like remote physiologic monitoring. And today, as it stands, there really is very little education or training for providers that exists or it is embedded within med school curriculum or residency training curriculum, let alone for our physicians that are currently practicing today. And we're only going to see an increase and an uptick in that technology and those capabilities. So it's going to be really important for us to engage our healthcare workforce and get them much more comfortable with the use of technology and what that means and how that changes their workflows, their reimbursement, their need to physically be in an office, the level of interaction that they have with their patients, and shifting the paradigm from meeting with a patient maybe once a year or 2 or 3 times a year for a snapshot in time into the ability to have continuous trends of data, not all at once, but at least aggregated for them to better understand what's happening in what we call the white space, but the time in between visits, which is when the real care really should be taking place. So what does that look like for a doctor who's very much used to seeing their patient just physically in the office with blood work that was from a week ago and a physical examination, which is from that day, and whatever the patient remembers from that given day? How do we transform that into longitudinal care delivery that's facilitated through technologies?
Thank you very much. Thank you very much, Jonathan and Dr. Tanya Elliott. It was quite interesting. My name is Norton Hurtado. I work with Doctors Without Borders, Médecins Sans Frontières. And while waiting for the answers from the people online, we saw the change on technology, Jonathan. We introduced telemedicine and Dr. Elliott for sure, but we implemented technology from telemedicine 10 years ago when we started to see only a dozen of cases. And the last year we saw more than 3,500 cases. And 400 cases of that was real-time telemedicine. So, Jonathan, what would you say to people who try to implement change and innovation with technology alone?
I think that one of the huge things we've seen with COVID is this explosion in the rate of change of technology. But as Dr. Elliott stated, there's a huge transformation that goes along with that in terms of the patient and the provider experience, how accepting people are of this technology, and how to make sure it also doesn't get in the way of the human connections. One of the things that we're very proud of, and the reason that we chose to focus so much on community healthcare workers, is not just the health care that they provide, but the health promotion and that community connection they provide. And I think there's lots of great lessons on how technology can be introduced to be non-disruptive. But on the flip side, I think we also need to not be scared to be disruptive within the healthcare settings, because a lot of things are poorly designed currently, and making broken systems slightly more efficient is not exactly a worthwhile goal. Some of the huge opportunities with virtual care, with telemedicine, with digital transformation for these workforces is to redo the system design in such a way that takes advantage of a patient-centered approach and the latest in technology. So we think there's a lot of lessons learned from different examples of direct-to-consumer that's exploded within mental health care, with direct-to-provider learning and training, and with technologies in between. But for a lot of these, it's important to double down and reinforce what's working. And a lot of that has to do with the provider and the patient relationship and interaction, and then redo what's not working, inefficiencies in the system and other components.
Thank you very much. And just following on that that answer as well, John. Which countries and communities does DIMAGI work in, and where do you support healthcare workers?
We work in over 50 countries in Africa and Asia, and we've worked in a total of over 80 countries in our history. We're very proud of the diversity of countries that we support, and we've seen all different economic segments within those countries and across countries. And the one commonality that we keep seeing over and over again is how dependent we are on the pro-social behavior of these frontline workers. They do so much for these healthcare systems. So do nurses, so do doctors, and so do many other actors in the system. But these community-based frontline workers provide an exceptional amount of support, particularly for underserved populations. And so that has been common across all 80 plus countries we work in.
Thank you very much. Dr. Elliott, now and then sometimes people get what we call health-associated infections while they're receiving healthcare for another condition. What examples have you seen of post-operative care happening virtually rather than risking infection by going back into the practices?
Right. So anybody that's immune compromised, anybody that's post-surgical, and then especially somebody who has an immune condition. So let's say they're received an organ transplant, for example. And I think Boston Children's Hospital does a great job of this, where all of their post-operative care for children that undergo transplants, organ transplants, the care is virtual, which makes complete sense. Asking a patient who has zero immune system to now physically go into a healthcare setting where we know there's a higher risk of infection simply just shouldn't happen now that we have the technology and the care that we can bring to the patients. Layering in, additionally, not just relying on maybe somebody's home thermometer, but home physiologic monitoring with things like biosensors, where you can actually baseline the patient prior to their surgery and then see how they're doing post-operatively. You can evaluate their skin temperature, whether or not they're ambulating, what their heart rate is, what their respiratory rate is. And we'll see more and more of these devices coming on where we'll be able to, just with a single patch, be able to check blood pressure, be able to evaluate pulse oximetry. So you'll have all of the objective data points and information you would need. And to some extent, as I was saying before, even better than an office setting, because in an office setting, I'm checking your blood pressure and your temperature at 9 a.m. But I have no idea what it was at 8:55 or 8:50 or 8 a.m. or 7 or 6 or what it was in the middle of the night. And with remote patient monitoring and allowing for that continuous data stream, I can now see what your average temperature was over the last hour, as opposed to the snapshot and time temperature. So we will see it becoming more and more quickly standard of care. One just thing to, talk, jump on what Jonathan had said is, what's really interesting about your work, Jonathan, is you are taking a frontline worker who previously didn't even have a voice and empowering them through technology and saying, hey, they're doing all of this work and we're not able to even track or account for it. And it's so important. And they're doing this education and we can't even do anything to quantify that. And so you're leveraging technology and embedding technology so that you can do that, so we can get credit for that care and empower that workforce. And that's really important. And I also think it's a really good place to start in technology, because they didn't have technology before. So you are solving a problem where previously these people went unheard and their care went unrecognized that they were providing to communities. One of the challenges with traditional healthcare is are we going to rip and replace the existing technology? And not only that, the existing technology that we have, the electronic health record, in-basket messages for providers, it is the bane of their existence. You see more and more that it is correlated with physician dissatisfaction. So I challenge the people that are listening here today. So let's think through solutions. I love thinking about net new solutioning, where maybe the answer is just a frontline caregiver that doesn't necessarily have a background in healthcare, and then they are supported and they can escalate to a provider, but that provider is not chained or tied to an existing infrastructure and an existing technology, existing real estate, and existing EHR. So maybe we should think about new care delivery models. And I love maybe starting with the people that are already in communities. And we know that already works. We've seen the peer-to-peer work for blood pressure reduction. So not just for monitoring or surveilling patients, but also managing chronic conditions. So I really like this model, and again, challenge everybody listening to let's think about innovative care delivery models and recognize the challenge of a rip and replace model.
Thank you very much, Dr. Elliott. Quite interesting. And it's a good segue for the next question that we have. It's for John. Could ComCare ever be used as a telehealth platform to connect patients to providers in this innovative way?
Yeah, it's a great question. And to build on what Tanya had just spoken to as well, we acquired a company earlier this year that was focused on patient adherence for tuberculosis. So in the United States and many other jurisdictions, if you were diagnosed with TB, you are legally required to take your medications, or you can be quarantined. And observing that taking of the medication requires the patient traveling to a clinic and having a nurse or other healthcare professional observe them taking the therapy. The company we acquired, Shirt here, built a digital component where you can asynchronously record yourself doing this, submit it to the nurse, and she can watch it at the end of the day in bulk. So it's a better patient experience, it's a better nurse experience, and it's more efficient for everyone. And so a lot of the benefit of these wearables and new technologies, it's a 2-for-1. It's better healthcare, and it's also a better patient experience. And there's a lot of win-wins here that are going to lower cost, improve the patient experience, and end up with better healthcare. So we're taking that Shared Here platform and entering the clinical trial space and supporting international growth of observed therapy for not just tuberculosis, but also opioid treatment for medication-assisted therapy that also creates a better experience for the patient, for the provider, and lowers cost overall. So absolutely, virtual care in these areas is a big area for expansion for Demagi.
Thank you very much. And it's been quite interesting. And after all we have discussed today, what ultimately makes you the most excited about the future of telemedicine and the improvement of our healthcare processes? A question for both of you. I will start with Dr. Elliott, please.
There's so many things that get me excited about this space. I think probably remote physiologic monitoring and asynchronous care delivery. So, we got really good at the telemedicine 1.0 during COVID, which is sort of what we're doing right now, which is a real-time audiovisual interaction. But I really like, and so it's almost to some extent replacing a brick and mortar. The difference is now we're not physically in the same location, but we're speaking synchronously. What excites me the most, though, is the asynchronous interaction. What you just described, Jonathan, around batching medication, video-assisted, medication adherence. Doesn't that make complete sense? Just record yourself on your phone taking your medication, and then a nurse doesn't physically have to trek all the way to a physical location, or the patient doesn't have to physically trek somewhere. But you also don't have to coordinate all at the same time. Someone standing there staring at you, watching you take your medicine. It can be done asynchronously. So think about what that can do for the current shortages that we're having with our workforce around physicians and particularly our nursing shortages. And then also the impact that it can have on communities that don't have access to care. So again, the asynchronous interactions that are not in real time, as well as the ability to now physiologically monitor patients and gather this data in aggregate, and then track and trend it over time, and then see what correlates with disease risk and disease progression. That is absolutely the future of medicine. It's not just the future of virtual care or telehealth. It is the future of medicine and healthcare delivery. And the last thing I'll say is just that we need to get with the times and make sure that we're actually training our clinicians and care teams so that they're able to provide this care. Because guess what? The technology is already there.
Thank you. Jonathan?
Yeah, just to add, I think that was a great summary from Dr. Elliott. And our only piece is focusing on that provider and making sure she or he has a better job. At the end of the day, this work is challenging. It requires a ton of innovation going forward. It's going to get more expensive. We need more funding going into low resource settings. And it's all got to anchor around the people providing this care and how do we make their jobs great so that they can create amazing outcomes for their communities.
Thank you very much. Amazing discussion. I'm really excited to see the future of telemedicine in health. Thank you.